Welcome to the next installment of UOA On Demand. The topic today is going to be urgent orthopedic care, and I'm pleased to be joined by two friends and colleagues, Dr. Jamie Monica, who's a hand and upper extremity specialist here at UOA, as well as Dr. Justin Fleming, who is a foot and ankle specialist as well. So, gentlemen, it's great to see you. Looking forward to having a good discussion today about kind of urgent care of orthopedic injuries. And, I want to start, we have kind of an upper extremity specialist as well as a foot and ankle specialist. And these are very common things that I think patients experience, and certainly common injuries we see in the office. So, Jamie, to you first, can you maybe talk about the common orthopedic injuries you see referred from an urgent care, and kind of how we manage those here at UOA, and kind of give patients a flair of what you're seeing and how you can treat those.
Yes, thank you. Thank you for having me. Thanks for joining us, everyone. We see a lot of fractures of the upper extremity, anything ranging from the shoulder down. More commonly, for urgent fractures, usually involve some type of displacement. So they come with x-rays from the urgent care and sometimes a splint to try to help immobilize the fracture. Probably the most common fractures that we see involve the wrist, and they're called distal radius fractures. Then in the hand, metacarpal fractures are very common. That's the bones mainly in this part of the hand. And some common fracture names include a boxer's fracture, which patients can get on this metacarpal here, or if it involves the thumb, it's called a Bennett's fracture. And then fractures in the fingers as well. So fractures are very common, commonly transferred from urgent care centers. In addition to fractures, dislocations can happen. Those affect the joints when the joints basically come out of their usual location, and it's very common for us to see like a finger dislocation, either at this joint, or this joint. There's multiple joints in the fingers where that can happen. And then tendon injuries can happen either from lacerations or cuts, or they can just happen from rupturing. If someone grabs something really firmly and it pulls their finger away, that can rupture a tendon, and that's commonly called a jersey finger, named from grabbing a football jersey and then the jersey pulling the finger straight against maximal force when they're trying to grab the jersey. And then lacerations. We see some cuts or even some amputations that are very close to the tip of the finger, which need usually wound management or sometimes even surgery to help cover the wounds.
Great. Yeah, I think it's a great overview of what you're seeing. Justin, why don't you talk kind of a little bit about the similar thing of what the other end of the body, kind of from the ankle down, common injuries that will present to you that you're going to see in more of an acute or urgent fashion.
Yeah, well, it's interesting that the ankle joint is the most commonly injured joint in the body. So that's probably by and far what we see the most of. And those comes in a lot of different varieties, whether it's a typical sprain where the foot rotates inward. We see that a lot in basketball. We see that a lot in runners. And then there's a smaller subset called high ankle sprains. And typically we see those in contact sports. So particularly more in, perhaps in a football season versus a basketball season. Achilles tendon injuries, particularly ruptures, are definitely more common. As the summer months start to, people get outside, we start to see, a fair amount of those as the people that have been less active, like myself, start to become active, and then those injuries can occur. And then, probably ankle fractures in foot fractures. So ankle fractures typically are some twisting motions that can cause a break in either the inside or the outside or both. And then fifth metatarsal fractures, that's the bone on the outside. And if you're a sports fan, you've heard of something called a Jones fracture. That's an injury that sidelined Kevin Durant for an entire season. So that's, something that we see often. And then there's also this kind of spraining fracture pattern that we see in the top of the foot called a Lisfranc fracture, and also commonly seen in sports, but it can also be by someone tripping over a dog bone or a child's toy or something. So there's really a big spectrum of injuries that we see based on the season and the environment that they occur in.
Yeah, Justin, I think that's a great point. And I think I'd love to highlight that, there's a lot of injuries that having a specialist involved early on really has a lot of value for the patient. I think we all can think of examples where, someone goes to see either an urgent care or even to the ER, and there's a lot of question of, well, maybe it's a fracture or maybe there's a line. And I think one of the things that, we can offer by going right to a specialist is you can, provide very definitive answers about the injury, as well as kind of the treatment plan and the prognosis. That's something that oftentimes patients kind of come in with a lot of uncertainty and kind of angst, wondering, is this, something that needs surgery, and what's the timeline of that? I think certainly that we probably have all seen, and I don't know if you guys can think of an example, maybe along those lines, but I think that's a big benefit of being able to see a specialist rather than kind of going and then having to be referred to one, in a number of days later.
And Patrick, if I could just hop in and just kind of to illustrate your point, if we take an Achilles tendon rupture, for example, often patients will present to an urgent care because they're still relatively functional, although it hurts a lot. And oftentimes I may see those patients by the time they get through the urgent care and come into the office, they're already 2 to 3 weeks down the line. And that's the difference between having essentially a non-operative or immobilization therapy or treatment for your Achilles rupture or surgical treatment. And so you can use either of those treatments when you see the patient at time 0 initially, but after a certain time elapses, it eliminates the ability to treat it non-operatively. And so I think it puts a patient at a real disadvantage. And so, time I think is critical for some of these injuries.
Yeah, I would agree with that also, especially with the hand and flexor tendon injuries, where you really do have a limited amount of time, typically about 1.5 to 2 weeks to fix certain tendon ruptures or lacerations before it kind of changes the whole procedure that can be done to address those. And then also if a patient has a finger dislocation, for example, there's certain techniques that most urgent care or emergency room doctors use to reduce those, and a lot of it is just traction on the finger, but it depends really which direction the dislocation's in. There are certain subtleties about the x-ray or the presentation that really can determine what technique is used, and not seeing a specialist for that may create a simple dislocation into a more complicated one if it's not reduced in the correct manner. So, and there's multiple examples of that, as well as with fracture care. A lot of times, getting a reduction the right way can prevent surgery down the road if it's done early enough.
Yeah, I think that's a great point, Jamie, and brings up a little bit of, I think, where many patients are wondering or thinking, which is a lot about the pain control and management of that acute injury in an office type setting. I know that many of us will use some sort of digital block or a lidocaine type procedure to numb up a finger, similarly in an ankle, to be able to reduce an ankle fracture. But I wonder what your kind of experience is with patient comfort to be able to perform a reduction in an office and not kind of have the setting of a hospital, because I think many people think you need that. But the reality is that, with a well-placed digital block, hematoma block for an ankle, or certainly for a more distal extremity, we can really adequately provide pain relief with minimal kind of quote sedation, and certainly no risk of that sedation.
Yeah, absolutely. Even with larger joint dislocations like elbow or shoulder dislocations, a lot of times, even in the emergency room, orthopedic surgeons will just use an intra-articular injection or an injection within a joint without any type of sedation or pain medication. But it's also important to discuss that obviously with the patient and make sure they're on board with that, and stop it if need be, if they do need more pain control.
Yeah, Justin, I'm curious what your experience is with splinting and an ankle fracture. I think certainly in orthopedic residency, we learn the value of a well-molded splint to be able to maintain a reduction. And I think sometimes not doing that and not having kind of the correct splint applied can be detrimental, and you may see something that shows up that isn't either as optimally reduced or has kind of lost that reduction. So I'm wondering how you may speak to kind of how that affects the care down the road for an ankle fracture, for example.
Yeah, I think to your point, that situation is really deleterious in patients who have unstable injuries that need surgery. And by definition, something that's unstable doesn't want to stay in place. And as you spoke about, unless you're doing it frequently or you have some type of educational training on it, the odds are that you might not get it right. And that's because it's difficult. And the problem is for the patient is that over time, if it's not done well, the bones can slide back into their position of injury. And in the foot and ankle, there's not a lot of fat, there's not a lot of skin, and the bone comes up against the skin, and that creates skin breakdown, and that just kind of complicates the surgery, complicates the approach, and it complicates a lot of things. And so ideally, a well-padded splint and a well-molded splint is important. And then also recognizing which things really can't wait. There's a subset of ankle fractures that will never really stay reduced, and those patients really need to get to the emergency room, to the OR. So it's just kind of having a watchful eye on the type of fracture and then understanding the best way to immobilize it.
Yeah, and I think, interestingly, that's another topic to bring up, which is really how we can, provide either splints or braces and the correct immobilization. Certainly splints sometimes can be, relatively bulky, and many times patients may not need that. I'm sure, Justin, kind of a lower extremity boot or a cam boot is a common thing you would prescribe or give to someone in the office. So maybe talk about how you use those in the acute settings rather than a cast or rather than a splint when you're, obviously confident they can do that treatment and do it well successfully.
Sure. So more times than not, the injuries that we see are stable and they don't require surgery and they don't require casting, and they can be immobilized and protected in a walking boot. And so, if you've ever been the unfortunate patient where you have to be on crutches and you can't take a shower and you have a splint and it's 90 degrees outside, it's relatively uncomfortable. And so the ability to get in a boot, to take it off to ice, to exercise the ankle and to put weight on it, it really improves the quality of life, and it decreases the chances of bad things happening like blood clots and muscular atrophy and all these things that go along with immobilization.
Yeah, and Jamie, I'm kind of thinking in an analogous situation. You probably see a number of patients who show up in kind of an Allumaphone type splint, where really maybe they need a certain type of mallet finger device or something. So maybe talk about what you can do in the office with very specific treatment for certain injuries in the finger.
So you're right. More often than not, patients do present with a splint that kind of over immobilizes the finger and sometimes even parts of the hand, where really just one joint needs to be splinted. And sometimes they don't even need a splint, rather just buddy tape is a more appropriate treatment option, where we just tape two fingers together using a good finger to kind of help support the injured finger. But that also allows for early range of motion and avoid stiffness, which is something that we often have to take care of if the patient presents later after being treated with a splint from an urgent care. So yes, we do have special types of splints for all types of injuries. In our Wall office and our Somerset office, we have occupational therapy where we can make plastic removable custom-made splints, which are really helpful, especially with the warm weather months. And then if there is a fracture that needs more rigid immobilization, we have all types of casting materials, including waterproof casts, which patients can get totally wet in air dries in about 30-40 minutes. They can go swimming with them. So there's a lot of different options for immobilization.
So I think, Jamie, that's a great point and highlights, I think, another topic that I wanted to bring up, which is really about the availability of on-site X-ray, which we have at all of our facilities and all of our offices. I think X-rays are something that patients assume are basically interchangeable and all the same, but the reality is that knowing certain views to find more subtle injuries that may be hidden in plain sight, and then having a specialist interpret those, I think is a very important thing to highlight that we have when you're working with an orthopedic surgeon and working with a specialist in that type of an injury.
Yeah, definitely. Even us helping the X-ray tech position the patient for certain X-rays, or getting contralateral X-rays of the other side for comparison are definitely very helpful.
Yeah. And Justin, I'm curious if you'll often use stress X-rays looking for problems that may not show up on the initial X-ray, and kind of the knowledge that to be able to do that gets the patient an answer very quickly.
Yeah, so 100% to your point, just getting them in and getting the appropriate X-rays are, that's the foundation for a lot of the diagnosis that we do in determining, what the treatment is. And stress X-rays are just our ability to see whether a fracture or a joint complex is stable or not, and that often determines treatment, and we have guidelines for that. But with our X-rays techs in our facilities here, it's very easy to obtain a view. If we don't like it, we can obtain another view. But it's the most scientific way that we can give you the most accurate diagnosis, the quickest diagnosis, and then eventually get you back to where you need to be.
Yeah, and one of the other topics I wanted to kind of mention is really about the on-site surgery center that we have at the Somerset office. And I'm curious, Jamie, how you use that for example, for a more acute injury, an infection, something that really needs to be addressed somewhat urgently, and how you can kind of address that very kind of quickly that day with the surgery center just on the 3rd floor, and you're seeing patients on the 1st floor.
Yeah, it's been very helpful, especially for infections. Sometimes patients come in acutely with a foreign body, such as like a splinter or a piece of metal that's in the hand that really should be removed as soon as possible in order to prevent evolving progressive infection. And then also sometimes patients come in like from an urgent care setting where they had an attempt at a finger relocation, and as I was mentioning before, kind of turn that simple dislocation into a really complex one, and it's not reducible now by just pulling or manipulating the finger, and we actually have to make an incision to open the joint. So that's also been very helpful to just have them head upstairs, and it usually doesn't require that the patient be NPO or not have anything to eat or drink before the surgery, because we can do those surgeries under local anesthetic also, where we just give an injection and then perform the surgery to either clear out the infection or reduce the dislocation.
Yeah, it's kind of amazing how our field has evolved to be able to do so many things in the kind of hand as well as the foot under local anesthesia, and avoid the complications from general anesthesia, which are rare, but certainly are things that we worry about, and a big benefit to patients when we can avoid that. I'm curious, Justin, many patients I think struggle with the decision to get treatment and whether they have to be seen that day. It's okay to wait for a day or two. What advice would you give for patients who have kind of an ankle injury, or they have some swelling after a fall, as far as when they may be able to be seen, and whether it's okay to wait if they can put weight on their leg, for example?
Yeah, I mean, I think that's a great question, and I don't think there's a great answer to it. And certainly everyone's pain tolerance is different, but certainly if you have an injury that we would consider to be high energy, that's a fall greater than 5 feet, a motor vehicle accident, perhaps even on a bike or a motorcycle, those injuries and that amount of energy tends to create more damage to the soft tissue and bones. So I would say there's certainly a greater urgency. If you feel like you have to kind of put the joint back in place, or you felt something pop, that's kind of a common things that people would say. I think there's more urgency to that. If you're able to put weight on the foot and you're able to, kind of get around, I think it's okay to ice, elevate, do all the things that we've been taught, and just see what the next day brings. But if the swelling is significant, your pain is uncontrolled, or you notice that, the foot or the ankle just kind of doesn't look the same or feel the same, I think it's appropriate. There's no harm in coming in early and letting us evaluate and put you on the road to treatment.
Yeah, and that's really, I think, what we want to highlight here, which is really we're here as resources for patients to be evaluated urgently. We certainly know these injuries happen and are common, and we're able to get patients in the same day. Certainly, we function kind of in an urgent care type setting in the office where they can be seen by a specialist, quickly. We certainly would encourage patients to call and kind of request these type of services. We do also accept walk-ins, for the office, and we're ready to treat these type of injuries, when and if they occur. I think a lot of times there's this kind of push to go to an ER or to an urgent care, but the reality is that the specialists are right here, and kind of, we're set up to treat them and get them answers quickly in a way that, really uses all of our knowledge and specialty specific focus that we bring with each of our partners.
Yeah, and to add to that, Patrick, I think in addition to the X-ray facilities and the surgery center, we just really are fortunate enough to have subspecialists in every area. I mean, there really isn't anything that UOA doesn't cover, and so I think that gives patients really a sense of security that if they're going to go there, they're going to find the right person to help them to get well.
Yeah, that's a great point, especially with patients who do have a fall and maybe they hurt their back and their elbow, or ankle and their elbow. There's usually more than one of us. All the subspecialties are usually covered, at one time during the day at each office.
I think that's great. Well, I think we've covered a lot here, and certainly I would encourage any patients to, look further, certainly of us on the internet, on our website, and we are here. We'd encourage you to call if you're interested in having an injury that happened recently, be evaluated. We can get you in and certainly take a look and get you subspecialty level care for your injury. So with that, I would just like to thank Dr. Jamie Monica and Dr. Justin Fleming for their time tonight. Certainly we'll look forward to seeing everyone both in this virtual setting as well as in the office in the future. So have a great day.